Related events are classified into 5 different categories. They include pathological fractures, patients with severe pain requiring radiation, the most devastating being spinal cord compression because it's hard to recover from that, excessive calcium from too much bone turnover, and patients requiring surgery to bone. The consequences of these skeletal-related events are really poor quality of life, regardless of which way you look at it, and eventually decreased survival. We know that patients who have a pathological fracture have a much higher risk of succumbing to their fracture because of complications. So somebody falls and breaks their hip, they come to the hospital, they require surgery, they're immobilized for weeks at a time before they get up and running, they get pneumonia, and eventually they pass away, not necessarily of prostate cancer, but of the complications of pathological fracture. So we can see that this is the same prostate and breast cancer, and so our job is really to look at finding these patients.
Dr. To interrupt you for a second, can I just ask you to put it up into presentation mode, into full screen mode? It just makes the slide bigger for the, there we go. Thank you so much.
Thanks. So we know from a study done approximately 5 years ago that zoledronic acid, which is a biphosphonate, significantly reduced the time to a skeletal-related event in patients who had prostate cancer. And with those patients, they did have medical oncologists do the bulk of the work because it's an IV drug and it's not really conducive for urologists to do it, but it's shown that there was a significant decrease in risk in patients who received placebo. And this is patients who developed the first skeletal-related event and also who already had one to develop a second skeletal-related event. So in comes the new drug called Xgeva or denosumab, which is an IgG2 monoclonal antibody. Works in a very different way, and it's a sub-Q injection. So they did a comparative study looking at patients receiving zoledronic acid once a week for 4 weeks versus a sub-Q injection of denosumab, and they found that overall denosumab was superior in delaying skeletal-related events in patients with metastatic disease and also from developing a second skeletal-related event. So these are the graphs that show that over time they both work, but denosumab seemed to work better for the first skeletal-related event to occur, which is one of the 5 categories that we talked about, and also for subsequent skeletal-related events. So certainly the quality of life is improved in these patients because it takes longer for them to develop the complications. They eventually, most of them do, but we can certainly decrease the time that they have or increase the time they have to improve their quality. So based on these studies, the CUA recommended guidelines for the management of these patients. So the most important thing is really for patients with a rapid rising PSA, doubling time of 8 months or less, they need to have a bone scan every 3 to 6 months. Even if they just had one 3-4 months ago, chances are there may be new lesions. If the PSA doubling time is greater than a year, they should have a bone scan at least every 6 to 12 months according to the guidelines. I find that as urologists, most of my colleagues tend to delay doing the bone scan or maybe don't think about it. And by the time they do it, often there's already significant metastatic disease, even with PSAs as low as 20, 30 in these patients, because these prostate cancers that tend to be high grade occasionally don't make PSA. So those are the patients that really will recommend, that are recommended to have denosumab or zoledronic acid for decreasing the risk of skeletal complications. We need to have these patients screened and make sure that they area, and we do a little bit of legwork to determine if they are candidates for that. And to let us know how we do this is Dr. Palmerville from beautiful British. Oops.
I just lost the screen. Hello, Horst? Hello? Horst? Hello?
Peter, yeah, Peter, I'm just at your bottom toolbar, there's those little icons. One of them is beside the Google Chrome one. That's the PowerPoint icon.
Yeah.
There.
Okay.
And if you go to present, it should pop up. There we go.
Okay. All right. I'll just advance to where I should be here.
Keep going.
So those are my disclosures. These patients are at risk for skeletal-related events and need to be monitored closely. And obviously, Joe talked about the importance of bone scans in these patients with rapidly doubling PSAs. I also feel strongly that a lot of patients that we treat today with prostate cancer often receive long-term use of LHRH agonists and antagonists, and a lot of these patients present early on with both osteopenia and osteoporosis, even before they are at risk for metastatic disease. And I think that one test that's underutilized by most urologists besides bone scans is a bone mineral density study. It's amazing the number of men that I see that have osteoporosis that's undiagnosed and needs to be treated. So the use of bone scans is also important, but I think also it behooves us to remember that we can order a bone mineral density study and we can actually anticipate or predict which patients are at higher risk for development of skeletal-related events as they move into treatment for their prostate cancer with an already compromised skeleton. In order to monitor these patients, whether you're using denosumab or zoledronic acid, you need to be aware of a few pitfalls. And as Joe mentioned, denosumab is a human monoclonal antibody which binds to rank ligand and decreases bone absorption, and in the process increases bone mass and bone strength over time. It's also, if you ever have a patient that's got hypercalcemia, you can use denosumab to treat that hypercalcemia because it will produce hypocalcemia. And obviously, at the baseline, you need to determine what the patient's serum calcium level is and then make sure that they're on daily supplements of calcium and vitamin D. The recommended dosage is 1,000 milligrams of calcium with 800 units of vitamin D. And it's important to check the levels of calcium approximately 2 to 3 weeks after the first injection and then before each injection. I think that checking calcium before each injection is really probably not as necessary as the guidelines suggest, and perhaps Joe can chirp in on that as well. Once you know that the patient's stable, I think it's you may feel more comfortable checking calcium frequently, but the risk of hypocalcemia with denosumab occurs within the first 4 to 6 months of initiation of treatment, so that's where you need to be careful and check the calcium on a regular basis. However, after that period, things are really quite stable, and I'll show you some data later that supports that argument. And then as the patient is on denosumab for a prolonged period of time, after, say, 2 years, then that's the other time when the risk for hypocalcemia can occur, and that's probably where you need to check it again. At the first visit, anticipating that you want to put a patient on denosumab, you need to do a quick oral exam or at least a dental history, and we'll talk more about that later on. Other tests that are recommended, which I must admit I seldom ever did, was magnesium phosphate and, on a regular basis, but sometimes creatinine. But denosumab doesn't affect renal function unless it's really severe, so it's fairly safe in patients who have an element of decreased renal function. On the other hand, zoledronic acid, which I use quite a bit in my practice, the problem with it is that it has to be given by intravenous injection every 3 to 4 weeks. The recommendation is every 3 weeks, and that can be quite onerous in a busy practice. It's also effective in treating metastatic tumors from prostate cancer, obviously. It can create hypocalcemia as well, and again, the recommendation is 1,000 milligrams of calcium with 800 units of vitamin D. You need to monitor the serum calcium again, along with phosphate and magnesium and electrolytes. But again, stabilization of the patient, you get a feel for what their levels are, and you can decrease the the monitoring over time. It's more important to monitor renal function with zoledronic acid because it is cleared by the kidneys. Again, an oral exam is important, and we'll go into that again. One of the often forgotten tests and a predictable test, I talked about bone mineral density studies and also bone scans, but the old alkaline phosphatase test, which we did many years ago on a regular basis, is important because it can reflect osteoblastic activity in the body. And when it's elevated, it often tells us whether or not there's going to be a possibility of metastatic development. And it can give you an indication of what serious problems might lay ahead for this patient. I think it's important to check it at the initiation of hormonal therapy because if it's elevated, obviously the patient has a poor prognosis and there may be rapid progression to bone mets, and you should be thinking about starting a bone-targeted agent to protect that patient. A single treatment increase in the alkaline phosphatase can indicate a single treatment failure and give an indication for referral for more aggressive therapy, i.e. chemotherapy. So if we compare the practical use of zoledronic acid to denosumab, obviously it's a little, from the point of view of the busy practitioner doing it in his office away from the cancer agency, which is, I think, something everyone should get involved in, it's easier to use denosumab than zoledronic acid. The reason for that is that it's a sub-Q injection, 120 milligrams every 4 weeks, and then the patient's coming in to see you for monitoring of their prostate cancer. It's easy to give them the injection when they walk into the office. You need to monitor the serum calcium, which we talked about. You need to be aware of the possibility of osteonecrosis of the jaw. And if you compare the cost between the two agents, you can see that there's very little difference for a year's treatment. Once again, if we look at adverse events occurring in the studies that both Joe and I were involved in using both zoledronic acid and denosumab, you can see that with the adverse events that are listed here, there's very little difference between the two agents. And then if we go further, you can see that the only difference between zoledronic acid and denosumab is the possibility of hypocalcemia, which is slightly increased with denosumab compared to zoledronic acid, and the chances of osteonecrosis of the jaw are slightly elevated with denosumab compared to zoledronic acid. But in favor of zoledronic acid is that, or in favor of denosumab rather, is the fact that renal failure needs to be monitored closely so the dosage of zoledronic acid can be adjusted appropriately. So hypocalcemia is a big concern and with bone-targeted agents, and we need to monitor the calcium whether you decide to use zoledronic acid or denosumab. And the recommended doses are slightly higher for patients over age 70. So I always tell the patients to take 1,000 units of vitamin D, even though it's recommended 6 and 8, and 1,200 milligrams of calcium for the patients over age 70. Risk of hypocalcemia with denosumab tends to be higher with the increased number of bony mets, and then that's really due to increased bone turnover, which can be measured in clinical studies with bone turnover markers. Patients on renal dialysis, renal failure, obviously are at increased risk and need to be monitored closely. If we look at the rates of hypocalcemia with denosumab, I mentioned earlier that the biggest fear with prostate cancer using denosumab is in the first 6 months, and you can see that it drops quite dramatically over time, and then greater than 2 years, it starts to rise again. So once you get a feel for the patient's serum calcium level, and if you know that they're compliant with their vitamin D and calcium, there's very little fear of a problem with hypocalcemia. Once again, if we look at the effect of using supplements in those patients who don't use supplements or forget to take them or are not reminded to take them, you can see that initially with the supplemental group, about 12% of patients had hypocalcemia overall, and only 15% of those patients overall with no supplements used in that group that were treated. And once again, it's the same with zoledronic acid in this situation. The chances of grade 4 hypocalcemia, you can see, is fairly rare, but once again, it's something that needs to be watched. And I think if you get a feel for your patient's blood levels over time, then you know which patients are highly at risk, and especially those that are progressing rapidly with increased numbers of bony mets. Those are the ones that need to be watched more closely than those that have maybe single or 2 or 3 mets. The risk factors of O&J in cancer patients needs to be considered, especially with these two agents, slightly higher with denosumab than zoledronic acid. These are the risk factors that you need to be aware of. So if the patients had previous dental surgery, there tends to be a higher problem with the O&J. If they have obviously poor oral health, you may not want to start them on the medication until they've seen a dentist. The longer duration of treatment with bone-targeted agents makes their chances of getting O&J a lot higher. Age also has a factor. Renal dialysis, smokers, and those who are being treated with other agents because of their disease. We look at the risk factors for the treatment and outcomes in O&J with prostate cancer. If they've had a previous tooth extraction or dental appliance, and obviously poor oral hygiene, if they're taking chemotherapy, if they've had limited surgery in the past, i.e. the treatment for O&J is to do a limited surgical debridement. And obviously patients that are identified, they tend to recover quite nicely with this treatment. Bone resection is not needed in the majority of cases, and resolution usually is seen. And in the studies done, there were very few patients developed O&J, but they did recover. I don't know about Joe, but in all of the patients I treated with both zoledronic acid and denosumab, touch wood, I've never had a case of O&J. The cumulative incidence of O&J in phase 3 trials, looking at both zoledronic acid and denosumab in advanced cancers, is presented here. And you can see that the percentage of subjects, it tends to rise with increased duration of treatment with bone-targeted therapy. So the patients you need to watch closely are those that have been on the medication for more than 2 years. What are the signs of problems that you might want to pick up in these patients? Well, if they have persistent bad breath, if they have an abundance of dental plaque and calculus on their teeth, their gums are bleeding when brushing or flossing, if they have some loose teeth, or if they've had unexplained oral pain, numbness, or bleeding. I think that in the population that I treated, most of the patients have good oral hygiene and see a dentist on a regular basis. I think you can pick out those patients that are really high risk for O&J, obviously this patient, and those that have been on the medication for more than 18 months. It's recommended that you take some kind of minor dental history, so asking the patient if they have oral pain, if they have loose teeth, or they're under regular care of a dentist for some problem that's ongoing. If they have loose teeth, multiple dental caries, if they've had fillings and crowns, ill-fitting dentures, obvious ulcers, some type of bone growth or exostosis, which can be palpated by examining the mouth. You need to document those findings and send these patients to see a dentist so that you can anticipate problems before they begin. So these patients that you suspect to be high risk for O&J, which I think are very few in most cities where patients take care of their oral health, referral to a periodontist or dentist is important. You need to consult with that dentist or oral surgeon if O&J develops, and you need to counsel the patients to adopt a healthy dental hygiene program while they're taking the medication. Thank you.
Thank you, Dr. Palmerville. I'll turn it now over to Dr. So, and I'll take the presenting privileges back. We'll just advance to the clinical discussion. Alan, over to you.
No, thank you so much, gentlemen. That was an excellent overview of the data. There was also some great practical points. I just also wanted to emphasize that the CUA has a very strong mandate to try to improve the education of bone-targeted therapy. There are a lot of things on the CUA website that the members can tap into regarding bone health, how to monitor for ONJ, how to monitor for oral health before initiation. I just want to open it up. Are there any questions from any of the participants? I'll start things up. I think for both Joe and Peter, one of the biggest concerns that I encounter with other urologists is the whole concept of the fear of ONJ. And you know, this whole point of osteonecrosis of the jaw, I think we've all seen these horrible pictures online and such. But you know, Matt Smith gave a very good discussion last month, and he actually said that ONJ in his practice is something of the past, especially with good oral health and good oral health counseling. Quite specifically, what do you guys do in terms of patient initiation? In terms of oral health, do you send all of your patients to a dentist? Do you just check the mouth yourself? And how do you give that message to the patient that when they see the dentist, they really need to kind of ensure that they tell the dentist that they're on these medications?
In my practice, I took the time to educate my office nurse. So she did the dental history, and she also examined the mouth. If she saw anything that concerned her, or if she felt that that patient had an issue with oral health, then she would bring it to my attention, and I would have a discussion with the patient and then discuss whether or not to refer to a dentist. And I must tell you that in all of the years that I've been using bone-targeted therapy, I never had to refer a patient for a dental consultation before starting any of the bone-targeted therapies. I really feel that it's not necessary to seek a dentist's opinion. The only time that I would get a call would be when the patient saw the dentist and presented the card to say, I'm on a bone-targeted therapy. If you're going to do anything to me, you need to discuss this with my urologist. And that happens.
What card is that? What card are you implying? Is that the Victory card, or is this the card that you give out yourself?
I gave the Victory card with an Osonab, and I gave a card of my own with zoledronic acid.
I've had an experience with one patient having had ONJ, and it was part of the study, so it was fairly obvious there was a large amount of exposed bone in the top part of the patient's jaw, and we sent him to a dental surgeon who basically treated him conservatively with some special mouthwash, and it went away. So I think the patients are more at risk if they do have requirements for a large amount of dental work, and if they've been on it for a while. Otherwise, I just use my pen that I use for transilluminating hydrogels to look in their mouth to make sure that everything's okay, especially if they have any concerns. Otherwise, it's fairly rare. It should not be a reason for not to use it, that's for sure.
Great point. When you then have started the patient, how often are you checking for their oral health, or is this something that you'll just kind of leave to the patient to tell you? Are you checking every 3 to 4 weeks, or?
No, I'd say probably every 3 months. Patients on denosumab, my nurse does the injections. I see them every 3 months, you know, unless there's any abnormal blood work. With the Victory program, it makes it very easy. They contact you if there's any problems. You don't have to remember to check or whatnot. And when I see them for every 3 months, I'll usually ask them. And, you know, I've yet to see a patient who complained of difficulty except for that one patient.
Great.
I have my office nurse, she gives the injection, talk to the patient. Are there any issues with your mouth? Have you had any problems? If they say no, we don't examine it. If they have any issues at all, then the patient's brought in to see me and I examine them out.
Okay. Are there any questions from the participants at all?
Just as a reminder, participants, you can unmute yourselves on in the WebEx or on the phone line, and if you don't want to ask your question live or you can't because of perhaps you're somewhere where there's background noise or you can't figure it out, you can always use the chat feature in the bottom right part of the WebEx to send your question to Dr. So, Dr. Zadra, Dr. Palmerville, or myself, and we'll ensure that that your question is raised. We still have plenty of time for the discussion here, so don't be shy.
One of the points that came up last chat, gentlemen, was the whole concept of length of time for treatments. And I know that this is a common question that I get from other urologists as well. Doc, how long are you going to keep this on it? I mean, as a reminder, most of the studies, left it to a 2-year kind of length of time when patients were given treatment but monitored for a longer time. For you guys, are you just continuing treatments of the denosumab after a 2-year period? These patients are living much longer now with the advent of AbbVie and Inza, but do you find that there's a specific cutoff point? Any comments as to what you guys are doing to try to determine when to stop, other than the development of ONJ?
I haven't seen any literature suggest that there's a specific time to stop, Alan. As long as the patients are doing well, they don't have any pain, their PSA is stable, they're reasonably healthy, and bone scan does not show any deterioration, I just keep them on it until I know that there is some literature to suggest otherwise.
I agree with Joe. I think that when the patient can't come to the office anymore for follow-up, that's the time that you have to consider stopping it. I don't see any need to stop when the patient's doing well, and obviously you're preventing skeletal-related events.
Would you still continue if the patient's progressing rapidly?
Yeah, I would. If the patient is still healthy enough, is still mobile to come to the office for follow-up, and it's still under my care, I would continue to use it. I would tend to stop when the patient starts to become more of an issue with respect to being looked after by the cancer agency or advanced chemotherapy and then is being referred to hospice. I think that's the time when you back off. But as long as there's benefit and you're showing benefit, then I don't see any risk at continuing, because ONJ has not been a big problem. Hypocalcemia perhaps is more of a concern at that stage, but once again, monitoring and supplementation usually takes care of that.
I must say, too, for the people who have not tried it or are afraid to monitor the patients very often, the Victory program does the bulk of the work for you. Minor issues to set up initially, and then they just take care of the rest. I think Janssen has gone well out of their way, Amgen has gone well out of their way to make sure that it makes it as easy as possible for you as the urologist to follow the patient and keep the patient on it.
I'd like to ask you and Alan about what your thoughts are about patients who are M0, who you do a bone mineral density study on, and they have advanced osteopenia or osteoporosis, and they're being treated with LHRH agonists. Would you use Prolia every 6 months in these patients?
Depends if they have a private drug plan or not, because I'm not sure if it would be covered in Ontario. So the financial component becomes, I think, one of the driving.
It's only $345 twice a year. Probably well worth the money.
If it's only that, you're probably right.
So for the audience members, the Prolia is denosumab given every 6 months at 60 milligrams, whereas the SRE prevention or Xgeva dosing is 120 sub-Q every 3 weeks. So again, the dosing is different. For my practice, I'm giving Prolia much more than before. I think it's much more well tolerated than Fosamax or the other oral bisphosphonates. There's no reflux, there's no heartburn or pain. So I think it's much better tolerated. And really, the rate of ONJ on the Prolia dose is exquisitely small. So it's really nothing to be too worried about. That being said, I still think that we need to kind of ensure that the audience remembers that for Prolia to work and for Xgeva to work, they really need to be on calcium supplementation to try to get that calcium back into the bone. Otherwise, these agents, and including bisphosphonates, don't work. Are there any questions from the participants at all? Here's a tough question for you, and maybe it's not so tough. Zoledronic acid versus denosumab, straight up question. You know, I think Peter Palmerville showed some of the neat differences. What is your preference? Why? Joe, do you want to start?
Definitely denosumab. When we were part of the trial, you know, although I have a clinical trial nurse or nurses, starting an IV was occasionally a problem with these patients. Having them sit there for half an hour lying down, the IV with interstitial, they can get a really bad reaction. We have to have medical oncology backup in case anything happened. Xgeva is very simple to use, and the literature suggests that it has advantages in patients with prostate cancer or solid tumors, metastatic bone. So I don't use zoledronic acid at all anymore. It's much easier to use denosumab to obtain the same results, if not better.
Peter?
I would agree with that comment because when I was using zoledronic acid, I had a number of patients have acute phase reactions with the medication, and that was enough to make them not want to take it. I must say I never saw an acute phase reaction with denosumab, even though it has been reported.
Yeah, I think without a doubt, there's level 1 evidence that suggests that denosumab is better than zoledronic acid. I think from the practical point of view, I think denosumab is better, except for one point, and that's the fact that zoledronic acid now is generic. So, you know, when you're in a situation in which cost is an issue, that might be the only advantage for zoledronic acid in this sense. But again, without doubt, in my practice, I'm trying to give denosumab as first line in patients for SRE prevention. Any other questions for the audience? Peter, you raised an interesting point in terms of the calcium monitoring. I just want to reiterate that what Peter said was calcium monitoring, although mandated by the CUA guidelines, which did follow the product monograph, which is to monitor the calcium. Peter's point was that hypocalcemia, if it develops, usually develops very early on, and that's what all the data is suggesting, that if you're having issues with hypocalcemia, it does happen early on. Peter stated that he doesn't monitor calcium after the first few months. Personally, I am monitoring calcium before every injection. And again, I think I agree with Peter, they're probably not necessary, but I'm just doing it just to kind of make sure that there's no risk of that reduction in calcium. Joe, what do you think about that point that Peter made? Are you monitoring the patients closely in terms of calcium?
I wouldn't say closely. I usually monitor them closely the first couple of months because that's when it's more likely to happen. I've yet to see somebody with abnormal calcium. Usually with the calcium, every 3 months, if we do a PSA, we'll do ionized calcium and albumin, not just serum calcium. If that's abnormal, then you want to know, is it because they're poorly, they have poor nutrition, or is it really true hypocalcemia? In which case, you just hold the denosumab for a month and increase their calcium. The treatment is relatively simple, as long as it doesn't become too severe a problem.
Any questions from the audience?
Alan, I have Dr. Reed. Dr. Reed, I'm going to unmute everyone because we're unable to get him his audio identified. So just give me one second, please.
Sure.
Okay, Dr. Reed, he can probably hear you now. Thank you.
Can you hear me now?
Yes.
Hello?
Okay.
Yep. I sent a message, Peter, but you may not have got it. I haven't ordered bone alkaline phosphatase in a generation. do you have any data to show its usefulness and why one should be ordering it in the initial assessment of someone with castrate-resistant disease?
So what to do? Just click on here for a second.
Yeah.
Do anything? No. Okay, so go back. One.
Does someone, Alan or Peter, do you guys want to field that question?
I've gone through all
Can
these
you guys
things.
hear me? Can you hear me?
Yes.
So that's a great question, Ian. I think that you're absolutely right. And again, Matt Smith discussed this at his last WebEx. So in general, it's very difficult to get the bony subtype of alkaline phosphatase. You can get alkaline phosphatase still, and it is actually a good predictor of response to denosumab. That's the first thing. And secondly, it is also a good predictor of bone health. When you have a high bone alkaline phosphatase, you treat someone on Xgeva or zoledronic acid, and it goes down. And actually, it's a good sign that you have a good bone strength and recovery in terms of the calcium getting into the bone. So it is definitely a marker that is used by some, but again, I don't use it. I don't think many of us use it because it's sometimes difficult to kind of manage these different tests
My email
and titrating it with treatment. So in general,
well,
it's a prognostic sign, but we don't do it.
If it doesn't change the management and it's hard to get the bone section of the alkaline phosphatase, it sounds more like a curiosity than something that's very practical. Or do any of the other presenters disagree?
I will order that on patients whose prostate cancer doesn't produce PSA. In those patients, you can follow the PSA to know what's going on, to know when to do the next bone scan. You do a bone scan, it's a lot worse, the PSA hasn't changed. Those are the ones that I think may be a niche for having the alk phos monitored because the PSA doesn't help you. So it's certainly not for everybody, just an extra way to the patient if you're not sure about what to do next.
I also have a question for Alan, if you could. What's the generic price now for zoledronic acid? And then what's the price difference? Because that has been the big issue in my province. Denosumab is to this point not covered because there's a substantial difference between what the cost of the two.
Yeah, I don't know. I do know that it is a significant difference in terms of the cost. In British Columbia, it is a perceived problem in the future. Right now in British Columbia, we're not getting anything covered except for when patients are palliative. And in that sense, both are covered. There's concerns and rumors from the government that they're going to be taking away denosumab because of the genericization of zoledronic acid. And again, it hasn't happened yet. And I think it's a concern. I think we do need to push back and let the government know that without a doubt, there's level evidence that denosumab is a better drug. So I don't know why they're trying to push zoledronic acid onto us, and it's more expensive in terms of administration, in terms of chair costs, et cetera. So I don't know. It's a tough question. I know that it's a lot cheaper. It's a drug that you have to give monthly for both, and for the government, they're seeing it as a cost advantage. But my response always to that kind of question is, look at the other options of SRE prevention, radium-223, which is in the exact same kind of MCRPC space. Now, this is a drug that costs $60,000 in the U.S., $40,000 in Canada. And again, when you put things into perspective, that plus Ambien enzyme, it really kind of lessens the actual true burden that denosumab has. It's a really cheap drug if you actually look at it to that perspective.
If I could, one other question. The third-party payers, have you had any difficulty getting denosumab paid for?
Gentlemen, did you want to answer that? For me, the answer is no. The third party has been very open to paying this with the correct indication, but I'm not sure. Joe?
No, we have had very little problem with patients under 65 who are not covered by the Ontario Drug Plan. They have paid it and then some.
Okay. one of the issues here is that Zolmida is given in the hospital, and denosumab can be given in the office, and that is an issue for payment as well. Blue Cross, for example, will fuss over this. If it's a hospital drug, they won't pay for it.
Yeah, I've heard that. At our system, we're getting the treatment either here in our office or at an infusion center nearby. So it's I can't answer that. Peter, Joe, did you have any issues with hospital administration disturbing your ability to get reimbursement?
Not in Ontario.
No. Okay.
Thank you.
As well. There's some. I know that there's some jurisdictions that it's not only covered when you actually have someone in your daycare getting intravenous. So that's obviously very inefficient system. So hopefully we can get this streamlined into our offices, and I think that's why sessions like this are so important. Thanks, Ian. That was great. Those are great questions. Any other questions from the group?
Yeah, actually, I have one more. Sorry about that. Joe saw an osteonecrosis of the jaw. Give me a little more detail of what it actually looked like, please, so I know what to look for.
Basically raw white bone.
Really? So it's actually necrosis, not as much of the bone of the jaw, but of the mucosal and muscle tissues that cover it. Is that right?
Correct. So I think the gingival component covering the bone is gone, and it's bone being exposed. So
is the bone itself necrotic, or is it just the soft tissue?
No, it's just the soft tissue. I think the bone itself just looked white, and it didn't. So there was no gum line on it. There was no like mucosal covering at all, and it wasn't a very large piece, but it was large enough that you could tell the surrounding area.
But the three of you have described bone resection, so I presume if this gets more advanced, the bone gets necrotic too?
I can answer that. My experience, I've had, so again, the O&J, the definition, although it says necrosis of the jaw, purely is just exposure of the, just like Joe said, exposure of the jaw itself because of the loss of the epithelial tissues, muscles, etc. on top of it. I've had a few O&J patients, and not one of them actually had any kind of surgical resection. And in general, when I do send them, all of them, to some type of endodontist or oral surgeon, periodontist, to try to help out, and they would inevitably come back with some type of rinse, rinse, antibiotic rinse, something like that. So it's treated. Now, the cases that I've seen, they've actually resolved. The literature, though, suggests that in some patients it doesn't, but in essence, sometimes it doesn't need to. Not all of them actually have pain, but without a doubt, if you do see this, and if a patient is saying that they're thinning in their mouths, you do need to take a look and send them off to a dental a dentist. But again, it is still rare, and this was again not what Mike said. Matt Smith, who is considered a leader in this in the U.S. in terms of bone targeted therapy, said that he didn't see one in the last 2 years because he's so good at trying to prevent it. And I think that's a key point. If we try to do everything we can to prevent it, and make sure that good oral health prior, then it's something that we can really do, can avoid.
The patient's greater that are patients who have dentures above and below, so you got to take the dentures out if you're going to look at them properly above and below. Sometimes they lose weight, the dentures get loose and it rubs, and it just gets the whole process going. I think it's a secondary effect of probably poor hygiene today.
Peter, any comments on that? No.
Can't hear. Peter's talking, but I can't hear him.
Peter, you have to unmute. We can't hear you.
Yeah. Peter's talking, but there's no sound.
Peter, it shows you as being unmuted, but for some reason we can't hear you talking. Can you just check on your end?
Are there any other questions while we get Peter to fix his computer? Any other questions from the group?
Well, at the risk of being monotonous, I'll throw one more at you. One of the issues is when to actually initiate bone-targeted therapy. And there's, I mean, I certainly, in patients who have a rapidly rising PSA, even if their bone cancer is negative, if they're castrate resistant, it's pretty clear that they're very likely at high risk of developing them imminently. I've been giving it quarterly, really on nothing more than comments I heard from Fred Sod. Any comments about initiating this therapy before radiological evidence?
I think there's some early research to suggest that it's probably helpful to prevent, once again, the first skeletal-related event. Part of the problem, at least in Ontario, is for patients over 65 is coverage. It will be covered only if there is even one small bony mess. It's not covered if you have visceral mess, for example, with a rise. Only if you have at least one or more positive hotspots on bone scan. So I think it's just a matter of time before the next progression is, okay, let's use it earlier, and it'll probably help more, but the question is having literature to show that, to be able to make sure you're doing the right thing.
Yeah. The comment I had about osteonecrosis of the jaw is that I think we need to be clear about the problem. And when I spoke to the periodontist in the building that I practice in, he said that most of these patients present with ulceration, not ONJ. So, Ian, when you talked about necrosis of the jaw, that is a loss of bony structure supporting the tooth. Joe's case, even though it was called ONJ, was probably just ulceration of the gingival covering of the bone. And that's why it responds to mouthwash and usually some grafting of the gum.
But is that a precursor, Peter?
It's a precursor. And that's why when Joe talked about the dentures and rubbing, that's a very important thing to check in someone that doesn't have their own teeth. And once again, these problems, according to the dentist, occur with prolonged use of these bone-targeted therapies. They don't tend to occur early.
Are there any other questions for the group? This is a question for both Joe and Peter. In your own practice, how do you have it set up to give these bone-targeted therapies? Are you giving the infusions / sub-Q injections yourself? Do you have a nurse giving it? How are you ascertaining dental health and monitoring calcium? Joe, did you want to start on that?
Sure. Well, the question is, how do we give it? I have given it myself. It's fairly straightforward, but usually, because it's only injection, my nurse will give it 2 of the 3, if not 3 of the 3 times, and I'll see the patient every 3 months. I will have a quick look in their mouth to make sure that there's no significant pathology when we initiate the denosumab, but not afterwards unless there's any specific problems, and we just usually ask about it as a routine. I don't give hyaluronic acid in the office. It's just not practical.
Peter?
I would agree with Joe. I've gone away from zoledronic acid altogether, and denosumab is my go-to medication in these patients. I think that the ease of use, the simplicity of educating your nurse to be able to do a dental history, to examine the mouth, make you aware of any issues that might be developing is very important. And it makes the treatment of these patients very easy, and I think you really do improve their quality of life greatly by being able to use this bone-targeted agent on a regular basis.
So you mentioned that you don't use zoledronic acid. I think this was brought up earlier. I agree with you guys that denosumab is superior in efficacy when you're looking at SRA prevention. Level 1 evidence based on the 103 trial, without a doubt. I think that the only reason why I would personally would ever give zoledronic acid is just because of the fact that it's generic. And we brought this up earlier, that because it is generic, and in some situations in which funding is difficult, this might be a situation in which you can give something. I think, in summary, my 2 points are, number one, I think these treatments are easy to be done in your office. Zoledronic acid, because the IV infusion is much more challenging, but still can be done. Zoledronic acid is generic and a little bit cheaper, but there's no doubt that denosumab has superior efficacy. So I think that the bottom line is that the most important point is that these patients with metastatic CRPC should be on a bone-targeted therapy. And as part of all of our guidelines, CUA, AUA, NCCN guidelines that they're on it, and whether you choose denosumab or zoledronic acid is not the big issue, but I think when it comes down from a practical point of view, it appears that denosumab's better. Are there any questions, points regarding that? It'd be nice to hear from the audience as to their take-home points as to how they give it. Any questions regarding administering it? Do you guys have any issues with the refrigeration of the? Oh, hello. Is there a question?
Yeah, I was just thinking, do you see any role of these therapies for example, a newly diagnosed guy with a PSA, say 200, the bone scan is still negative. Do you really, get microscopic exam? Do you envisage any role for intervention?
Sorry, Zolti, the sound is a little bit odd. I know the question just was brought up on
sorry about that.
So the question is, if I'm correct, is there a role in administering a bone-targeted therapy in a high-risk patient that's still M0, so the M0 CRPC? Peter, Joe, do you want to answer that?
Yeah, I think there is an indication for that. In fact, I'm a big believer in doing bone mineral density studies to determine whether or not that patient is at risk for either severe osteopenia or osteoporosis. And a lot of these patients who, especially those who have had external beam radiation therapy, have been receiving LHRH agonists or antagonists before the treatment of their prostate cancer, maybe as much as for 9 months. And some patients have been exposed for 4, 5, 6 months after completion of radiotherapy. And we do know that osteopenia occurs within 1 year of the use of LHRH agonists or antagonists. So if I have a patient with a high-risk prostate cancer that has been treated with LHRH agonists or antagonists for a prolonged period of time, I will do a bone mineral density study and check to see if they are at risk for osteoporosis. And I will start them on denosumab 60 milligrams every 6 months, which is Prolia. I really feel that you give the patient an advantage in that you're going to give them good bone health before they develop their problems of potential severe osteoporosis as a result of not picking up on it. And then they're going to get a skeletal-related event. And I think these are the patients that end up having a severe fracture or some type of catastrophic complication associated with their prostate cancer because they haven't had good bone health going into their advanced disease.
So that's a great point. I just wanted to clarify what Dr. Palmer was referring to is Prolia, which is denosumab at the 60 milligram dose, which is indicated for C-Tibble or cancer-induced treatment bone loss. The indication right now for SRE prevention is clearly M-positive disease, CRPC. And remember that the FDA did not give the indication for M0, so the prevention of development of METs primarily because of the risk-benefit ratio. But the bottom line is I agree with Peter in that we really do need to kind of amp up our game in terms of bone health and these men with androgen deprivation. And those patients with very poor bone mineral density are very high risk. And I think there's a distinct role for either bisphosphonate or a wrinkling inhibitor prior to developing metastases. And I think we need to be considering this at the time of androgen deprivation. Joe, did you have any comments on that?
I agree with you guys. I think M0 patients are rarely M0 for very long. They usually tend to progress fairly quickly, especially with the PSA doubling time. We're doing a study now exactly to look at this, looking at some therapies for M0 patients. You know how difficult it is to find an M0 patient, putting through a bone scan and a CT, and clinically define that there's no METs. So that's what you need to do. And some of them with a PSA of 15 that goes to 30, boom, they've got METs and didn't 5 months ago. So although the indication isn't there, I think we have to be right on top of the game and ordering the bone scan, even every 3 months if you're suspicious, to get them on the indicated dose as soon as, you know, one MET develops.
Yeah, that's a good point. The CUA guidelines, the CUA guidelines are recommending bone scans every 3 to 6 months. I'm not sure how many of us are actually doing that, Joe. I mean, I think we are starting to do it more, but I agree. I think we always have to be cognizant of that M0 patient. Are there any other questions? Pardon me, Joe?
I said I think we tend to keep that in the back of our mind, but it should be more at the forefront. I've certainly been unpleasantly surprised with telling guys, oh yeah, don't worry about your PSA's fine, you know, yeah, we'll do a bone scan in a couple of months, and boom, he's got 5 METs where he didn't before. So I think you can't do any harm by doing a bone scan, find that it's negative. If anything, it's reassuring for you as a treating physician that you're still doing the right thing, and for the patient as well.
Yeah, completely agree. Are there any other comments from the audience? One question that we brought up on the earlier session and always comes up, and this actually came up with Max's talk, is the fact that we know that it is advantageous and improves SRE prevention, but how long do you keep these individuals on a bone-targeted therapy? Is it something that you will discontinue after 2 years? Will you discontinue it when they go on to ABI or ENZA? We discontinue it when they go on to radium-223. What are your comments on that, Peter?
You know, I just went to the Western section of the AUA, and one of the sessions was on metastatic prostate cancer, and they presented about 8 or 9 cases, different scenarios. And there wasn't one of these cases where patients were early, middle of the stage, or end of the continuum where they actually gave any patient a bone-targeted therapy. I really feel that it's essential you start early and you continue to treat for as long as you possibly can. And in my experience, I would continue to do that until the patient no longer is able to come to the office for assessment and injections. And at that point, they're probably not they're not going to be receiving any chemotherapy, and they're probably going to be referred to hospice. I don't see any great disadvantage of continuing therapy for a prolonged period of time. I think it only has advantages and benefits for the patient.
I agree with you, Peter. Once the patient has started, I usually tell them they're on this for the rest of their life, and hopefully it's a long one.
Yeah, that's a good point.
Are there any other questions right now?
How dangerous is the ONJ actually for the patients? You know, how threatening is it? I have never seen that. What happens?
That's a great question. So the question is how dangerous, how common is ONJ? Joe, do you want to start that That's a common question that we had in the first session.
I think it's something that when people look at the clinical trials, the first thing that they see as side effects is osteonecrosis of the jaw. I've done a lot of those trials along with Peter. I've seen one. I don't think he's seen any. And I'm not even sure if it was true osteonecrosis of the jaw. It was more a deepithelialization of the gingiva to expose bone. So number one, it's extremely rare. Two, if you're suspicious, you just send the patients to an oral surgeon. And I've never had anybody who's I've heard of that has actually required surgery. They usually treat them conservatively with mouthwash and better hygiene. The patients high risk are patients who have dentures, both top and bottom. They're losing weight. The dentures are loose when they chew food, and they eventually get gingivitis and gum erosion, which can lead to exposing some of the bone in the jaw area, either upper or lower. Those are the people that are most, once again, most things, it's less than 1%. So, you know, Peter and I have a lot of patients who may have 20, 30, and anyone someone, you know, we probably have to double our output in order to find another one. So it should not be a contraindication if you're concerned about that.
Peter, did you have any comments on that?
Yeah, I would agree with all of that because I think you just need to consider who the high-risk patients are. You know, obviously the elderly patient with poor oral hygiene who is at end-stage disease, they may be the ones that will develop O&J. The younger patient perhaps that has had a lot of dental surgery for whatever reason may be at risk. But, you know, the initial examination of the mouth, the good dental history, you know, if you do have a nurse in your office, they just love to look after these patients because they feel like they are their patients. They do the injections, they do their history, they check their calciums, they call me when I need to see the patient. So I think O&J has been really overdone. Maybe it's just my luck in not having ever seen a case, but I think that from what I've read and what the literature says, O&J seems to be a bigger problem in other types of cancer than it is in prostate cancer. And I think from my recollection, it was multiple myeloma where they found more cases of O&J than they did in the other solid tumors.
Yeah, my take on O&J is something that it's real. I've seen a few cases of O&J. Unfortunately, many of them weren't very symptomatic. One was. It's something that we need to be cognizant of. And as I mentioned in the earlier session, Matt Smith, who probably has the highest volume of study patients on bisphosphonates as well as denosumab, has stated that O&J now is a really disease of the past because we're doing such a good job in identifying patients at risk. And I think Peter did a great job mentioning that. And as well, giving precautions for patients. And Peter, what type of precautions are you giving patients? I know that you were mentioning a card earlier. Is this something that you're giving to all patients, or is it just kind of education?
No, I give it to all patients. Just a little card that they can take to their dentist and show the dentist, so the dentist, when they go for their annual checkup or their teeth cleaning, that the dentist knows, and that the hygienist can give maybe even a better examination than we can in the office, and then alert the patient to the dangers. And I think it's just communication between you, the patient, and the patient's dental people that look after them.
Okay. Joe, are you giving them anything specific? Do you give just a victory card that comes with the victory application, or do you give them anything else?
Not really.
Okay.
Most of the patients that I see have fairly good oral hygiene and don't even come close to having a problem. And once again, you just got to make sure to ask the question. And if the answer is no, I'm not going to look for problems.
I think it's important to make sure that the patient realizes that the medication to treat their bone disease can have an impact on their teeth, and that they should be aware of it, and they should mention it to the dentist that they see on a regular basis. Because if that dentist is deciding to do something to them and not aware or forgets to ask about these medications, then the patient could get into trouble. So I think an ounce of prevention is probably better than a pound of cure in this situation.
Yeah.
Okay.
Sorensen, I'm interested on your Prolia experience because I've thought about doing this for a long time, but of course, even with private drug carriers here in Ontario, Eastern Canada, they've sort of been resistant to cover it. So I've had to resort to oral biphosphonates and until such time as they get to the point where they've got metastatic confirmed disease. I guess the question is, how are you having good results?
Yeah, I mean, I don't think it's that expensive. You know, it's in BC, it's about $345 every 6 months, and most patients, when you explain to them the reason for it, are quite willing and accept the fact, and will purchase it if they can't get third-party coverage. I'm very aggressive in trying to determine whether or not that patient is at risk. I really feel that if you have a patient who is osteoporotic or osteopenic in the M0 stage of their disease, and they have high-risk prostate cancer, as Joe said, it's only a matter of time before they develop metastatic disease. And I really feel that if you treat that problem early, the osteoporosis that is, or the osteopenia, you give them a better chance of not developing a severe SRE later on down the road. It's, again, being more aware of the fact that the bones are at risk and you need to have the healthiest patient you possibly can. So, you know, if you're going to look after their exercise tolerance and put them on metformin to make sure they don't develop, you know, some type of problem with the diabetes and heart attack and stroke, then why wouldn't you be aggressive in treating their bones?
In other words, preparing them for the battle that's forthcoming.
Yeah, it's getting all the ducks in a row, if you like.
Now, what if they don't have osteopenia, or they're sort of borderline on their bone density exam? Do you still?
Well, if they're borderline on their bone density, they're going to have osteopenia.
What about if it's normal? You still treat them?
If it's normal, I don't give it to them. No. I don't see there's a need.
Oral biphosphonates then, or you just stick with the calcium?
Nothing. No, I just tell them. I tell them to take vitamin D every day, but I don't tell them. And I check their serum calcium level to make sure it's in the normal range. So they may go on vitamin D and calcium, but I wouldn't put them on a bone-targeted agent if they have normal bone density.
So, along the same lines, or?
Yeah, the only other thing that I suggest to some patients is to be more physically active, go to the gym. I think you cannot build bone by sitting and watching TV, but you can probably build some bone and strengthen your bones by being more physically active, doing some mild weightlifting, just to get your muscles moving and to keep your bones a little stronger. That sometimes goes a longer way than just medication.
I think your points are well taken. As the more active you keep these guys early on, it gives them a little bit of reserve for the long term. For sure.
Yeah, exactly.
Yeah, you know, when you think about it, you know, Prolia, even at twice, I mean, that's a very nominal cost. That's certainly very.
I think it works out. I think in the end, it works out to be not as expensive or equal to using an oral bisphosphonate once a week. And to try to get a patient to continue an oral bisphosphonate, you know, they're really hard to tolerate. Never had a patient that really liked them, and I never saw the advantage myself.
Well, I think when you give the injection, you know they're getting it, right?
That's right. Yeah. And you have to remember to tell them to stay on calcium and vitamin D when they're taking Prolia as well.
Good point.
The risks with Prolia are a lot less than with 120 milligrams of denosumab every month, but the same cautions need to be given to the patient. You need to check their mouth. You need to watch their calcium levels.
Are there any issues with radium-223 and or at least if you're giving either Prolia or any of the medications, bone-targeted therapy?
I don't believe so. No.
In fact, Ron, there's actually good data to suggest that at least with bisphosphonate use, there's a subgroup analysis of the radium-223, the Alcempa trial, that those patients that actually were on the bisphosphonates with radium-223 actually had the best advantage in terms of SRE prevention. So it almost seems like the therapies, whether it's abiraterone or radium-223, they actually work better in conjunction with the bone-targeted therapy. So again, it just hits home the point that we really do need to kind of encourage use to try to maximize these patients, even when they go and move on. And I would never stop their therapy just because they're going on to a new therapy, but definitely something that I see as that will give an additive benefit. And we're seeing that on these subgroup analyses, both in radium-223 and as well as in 302. Are there any other questions at all? Well, thanks. I think that was great. Thanks again to the two speakers for their great insight into this treatment. And I just want to give it up to the group that we always say that this is easy to give and easy to treat, and it might be easy for us because we've been doing it. But without a doubt, I think that the initiation of this and the treatment of advanced prostate cancer is challenging. It's practice changing. You need to do a lot more assessments. You need to look for things like ONJ, and again, what the CUA is trying to do for everyone is to try to make this easier. One of the mandates that the CUA has and the Office of Education is to try to increase the accessibility of resources for its members. And again, this is just one of them. This is a reference tool to help in terms of initiating bone-targeted therapies. Next slide. There's also these sessions as well as sessions on ONJ assessment, dental treatment and such. That's available all on the CA website. So I encourage all members, all participants here today to try to go on and to improve there. And it's a website that I go into all the time. I just want to thank Dr. Palmerville, Dr. Zadra, and also the participants. I also want to thank the CUA. I want to thank, again, for you spending an hour of your time this evening. All your credits are available and a certificate will be sent to you. If you have signed in as a call-in user, please email Pal and send her your email and your name and tell her that you actually were participated. And again, I just want to thank everyone for the participation and the speakers for the great talks. Thanks again.